In this video, we're going to start about abnormal labor. So you'll understand this only if you see my videos on normal labor and partograph, because we're going to discuss about them also, like they are linked with each other. Okay, so let us see the abnormal labor. Actually, three things you see in a normal labor, right? What are those three things? You will see three P's. What are those three P's? If you remember, in normal labor I have discussed, one is passenger, one is the pelvis, and one is a push. So who is the passenger? That is the head of the fetus. Pelvis, it's required. And next, push, we need to push for the uterine contractions. Will push. Okay, so these three P's are essential for normal labor. Okay, so what is going on in abnormal labor is the push. The push is abnormal. There are abnormal uterine contractions, so okay, that is leading to one abnormality. And next, coming to the passenger. In the passenger is the OP position, that is occiput posterior position. It's an abnormal position. Okay, and also in malpresentations, there are some malpresentations, and also there are CPD, that is cephalopelvic disproportion. So all these three are passenger problems, abnormalities. And coming to pelvis, the abnormality is contracted pelvis, that is the pelvis is small, right? Contracted pelvis. Or you can take example of android pelvis, or anthropoid pelvis, or platypelloid pelvis. So these are all the abnormalities which you find in an abnormal labor. So in normal labor you require this passenger pelvis push. In abnormal labor, this passenger is getting it is the head of the fetus is coming from an occiput posterior position, and some malpresentations like breech, transverse lie, all those, and CPD, that is the head of the baby. Everything is normal here, but the baby is only feeling that the pelvis is shorter. Okay, so coming to pelvis, in pelvis the abnormalities are contracted, the pelvis is short, so now head cannot come. Or when the pelvic shapes are different, like anthropoid, android, platypelloid. Okay, so coming to push, here the push, the abnormal uterine contractions are not allowing for normal labor. So these are the reasons for abnormal labor. Now let us discuss the abnormal uterine action. First we'll start with the abnormal uterine actions, as we discuss here, right? This one, push. Let us start with this push. Okay, abnormalities. One is hypoactive uterus, also called as uterine inertia. Let us differentiate this with hyperactive uterus. Both are abnormalities only, right? If the uterus is hyperactive, that will lead to one kind of problem. If uterus is hypoactive, then that will also lead to one problem. So in the case of hypoactive uterus or uterine inertia, there is decrease in uterine contractions, okay, and decrease in number of contractions or strength, so there is slow labor. So this is the problem here. Coming to hyperactive uterus, there are increase in uterine action or uterine contractions. So there is increase in duration, increase in strength, increase in frequency. So three types of hyperactive uterus. You will see three types. The first one is coordinated. In coordinated, you will see that is a precipitate labor. Okay, and the second one you will see that is the incoordinated, that is inefficient or slow labor. And next you will see tetanic. Tetanic is basal tone. The basal tone of the uterus is greater than 20, that is slow labor. Now let us start with hypotonic contractions. So in the name itself you can see hypotonic means the contractions are low in this type of uterus. So either the number of contractions is less or the strength of contraction is less. So you need to see the number and strength. Okay, these are less. So it lead to slow progress of labor, of course. Slow dilatation in active phase is less than 1 centimeter. Okay, in active phase the dilation should be greater than 1 centimeter per hour, but here it is less than 1 centimeter per hour, so it is a slow labor. Okay, and the management is, so what you are going to do here in hypotonic type, you will just augment the labor. Okay, so how to augment the labor? You will just do artificial rupture of membranes. If you rupture the membranes, they will release the PGE2, because of this PGE2 there will be contractions. That because there is no contractions here, there is decrease in number of muscle fibers of uterine contraction and decrease in strength. So just you should rupture the membranes. Now coming to decrease if still contractions are hypotonic. Then after 30 minutes give oxytocin. Okay, so if you observe, you have done the artificial rupture of membranes, PGU2 release their contractions, but these contractions are like not that much sufficient for this labor. Then after 30 minutes just give oxytocin to this patient. Okay, next coming to partograph. So partograph, the fetal heart rate is normal. Let me show this partograph to you. So if you observe this partograph, you can see here the fetal heart rate is absolutely normal and there is no moulding. And the progress line right of alert line, you can see here this one is the progress. As you can see, it is a right of alert line, means I think it is a slow progress, that is there are hypotonic contractions. So you should artificially rupture the membranes and after 30 minutes also give oxytocin so that it will augment the labor. So according to the graph you have seen, right, the partograph. So strength and duration of uterine contractions will be improved after first artificial rupture, next followed by oxytocin. So the graph which I have shown you is related to hypotonic uterus, right? So we do the same treatment. So single vaginal delivery at 8, progress line did not cross the action line. So progress line is not crossing the action line, so there is no problem. It is a slow progress. You can give it to any intervention. If you're at lower center, you should go for higher center. If you're already in higher center, then just manage with this artificial rupture and give after 30 minutes give oxytocin. Okay, now coming to excessive uterine contractions. What is this? Excessive uterine contraction. Excessive uterine contraction, the words which we have discussed before, like tachysystole, right? Tachysystole means greater than 5 contractions for 10 minutes. 5 contractions for 10 minutes and less period of relaxation. So as there is no relaxation, this even though there are more contractions, it's of waste, right? Next coming to another one, hyperstimulation, where tachysystole and also fetus is already in distress. This type is hyperstimulation, we already discussed. Now coming to tetanic contractions. So what is tetanic contraction? It is a single contraction which is lasting for greater than 3 minutes. Okay, single contraction greater than 3 minutes. So only one contraction greater than 3 minutes, that is called tetanic contraction. Next coming to hypertonic uterine contraction, that is elevated baseline pressure. Already we discussed this baseline greater than 20 millimeters of mercury. So first we need to see all these important terms. Now let us see the risk factors for all this, for abnormal uterine contractions, both for hypotonic and hypertonic. Okay, hypotonic and hypertonic. So for both, what are the risk factors? Let us check out. Okay, so the risk factors are like 4 P's. You should remember 4 P. 1, 2, 3, 4. Okay, so what is the first P? That is a primi gravida, first time. Okay, and another P for malpresentation. Okay, another P for abnormal pelvis, and last P is for cephalopelvic disproportion, and also just add deflexed head. So in all these cases you will see either there are the risk factors for either hypotonic or hypertonic contractions. So even if you use injudicious use of analgesics and oxytocins, even sedatives can lead to hypotonic uterine contractions. So hypotonic uterine contraction can also be elevated because of using sedatives or some other drugs which injudicious use of analgesics, oxytocin, they lead to hypotonic uterine contractions. Now let us discuss about constriction ring or Schroeder ring and precipitate labor. Okay, so what is this ring I want to talk? That is a constriction or Schroeder. Okay, so what is this ring? Actually, excessive uterine contraction. This ring, excessive uterine contraction, coordinate uterine contractions, incoordinate, right? Coordinate will lead to precipitate labor, incoordinate will lead to spasm of uterus. Already I think I discussed here coordinated precipitate labor, incoordinate will lead to spasm of uterus, right? So because of this types of contractions, it will lead to ineffective contractions. Okay, ineffective contractions will lead to spasm of uterus. So whenever there is spasm of uterus, then forms a contraction ring. That contraction ring is nothing but it is presenting as prolonged labor. So whenever there is prolonged labor, you get this constriction or scrotal ring. Okay, so what are the risk factors? Same as for abnormal uterine contractions. So the same 4 P's you can remember here, or deflected, same risk factors even for this constricted ring. So now it cannot be seen but can be felt vaginally. You can't see these rings but you can feel it per vaginally. Okay, and it can be present in any part of uterus and it can be seen in any stage of labor. And Bandel's ring is seen only in first and only in second stage of labor. So let me say there is another ring called Bandel's ring, which is seen only in second stage of labor, but constriction ring or scrotal ring is seen in all stages and in any place of uterus. You can see this. Why actually this is formed? Because of ineffective contractions, that is mainly because of spasm of uterus this is causing. So let us see what is the stage of labor and what is the ring position and how to manage this. Let us start with this. So first stage, second stage, third stage. So in the first stage of labor, you will see mainly the ring position is at internal os, that is about this constriction or scrotal ring. In the second stage, you will see it is at ring position is at fetal neck. In the third stage, you will see that it is like a hourglass constriction, and it is seen at because of this there is retained placenta. Okay, and coming to management, so for the internal os, if the ring is at internal os, just do sedation. If the ring is at fetal neck, then give general anesthesia or use amyl nitrate. Okay, and when the ring is at third stage hourglass, then you do in general anesthesia and do manual removal of placenta. Okay, so these things we need to see. Now coming to precipitate labor. So precipitate labor means what? So hyperactive and coordinated uterine contractions. There is hyperactive and also coordinate uterine contractions. So because of this, it is leading to entire process of labor just within 3 hours. So just within 3 hours, entire process of labor is completing, and it is most commonly seen in multiparous female, small size fetus, and previous history of precipitate labor. Already they have previous history of precipitate labor, again they'll have precipitate labor. So precipitate labor is nothing but it's a very fast labor, just completing within 3 hours the baby will come out. So what are the complications like in the mother because of this? The complications in the mother are like she may have postparental hemorrhage, she may have lacerations, she may have tears, she have inversion of uterus. All these are problems because it is going on in within 3 hours, right? So in fetus, the problems are like intracranial hemorrhage and also asphyxia of fetus. Okay, and so how to manage this precipitate labor? The management is decrease contractions, so that the time there will be some time for labor. So for decreasing contractions, you will give general anesthesia and also use tocolytics. Okay, and episiotomy also should be done. Remember, episiotomy should be done in this case. Now let us check out what is going on in abnormal latent phase. So latent phase, actually it lasts until 5 centimeters of dilation of cervix, right? Normally till 5 centimeters, right? But if it is prolonged, then the definition will be in the primigravida, it will be greater than 20 hours, and in multigravida it will be greater than 14 hours, then you will say it's prolonged latent phase. So what is the cause for this prolonged latent phase? That is the thick and unaffected cervix. So cervix actually should undergo ripening process, but here it is not undergo ripening process. So this is an abnormality that the period of latent phase is getting prolonged. So how to manage this? Management is just to ripen the cervix by artificially giving some drugs or like this. Okay, so patient is in false labor, then diagnosis is no cervical dilation. So for example, if this patient is in false labor, in false labor also there will be no cervical dilation, right? So no cervical dilation means what to do management in case of prolonged latent phase? Use therapeutic rest, that is you should do sedation, then you can confirm like whether why it is going on. So if the patient is in false labor, then the labor pain will subside after sedation, but if the patient is in true labor, then the patient will get up and she is in active phase after sedation. Okay, this process is called as therapeutic rest. So what we are discussing, we have discussed about latent phase. If it is prolonged, why it is prolonged? Because still the cervix has not ripened. Okay, this till this okay. So for example, you have a false patient, false labor patient. So in her the pains are coming, but like she's not understanding whether it's a true labor or not. So for her you will give therapeutic rest or sedation. If it will subside, then you can confirm it's false labor. But if it is not subsiding, then it will convert into active phase and she will undergo into normal labor process. So now coming to active phase. So we have understood about latent phase. If it prolongs, what happens? Now coming to active phase. Active phase, it should begin at 6 centimeters dilation of cervix, right? But the abnormality here is that it's a slow progress of labor. Slow progress of labor, then protracted active phase. Okay, and if arrest, or sometimes it will arrest at active phase. So sometimes what happen, after active phase the baby should get delivered, but sometimes in some female there you will see that the active phase has got arrested, but in some female you will see there is a slow progress of active phase, that slowly it is going. That is, according to partograph, you can say it is between the action line and the alert line and the action line. Okay, that is called protracted active phase. So now let us discuss something detail about protracted active phase. So what it is saying? Okay, protracted active phase. So protracted active phase, it is the slow progress of labor. Here the dilation is less than 1 centimeter per hour, so it is very slow process. The causes are due to hypotonic contractions. The contractions are very low in the uterus, or it is maybe due to adequate contractions. The contractions are very adequate. So if it is hypotonic contraction, here the contraction are less than 3 per 10 minutes, or it will last less than 45 seconds, or you can say less than 200 to 250 mv. So here we need to do arm, and after that, after 30 minutes give oxytocin. Arm means you need to artificially rupture the membranes. After that give oxytocin in this case, because there are hypotonic contraction, right? And start with lower till adequate contractions are maximum with oxytocin. So in primigravida you should always give only 16 international units. In multigravida you should give only 8 international units of oxytocin. Okay, so now coming to adequate contraction. If in the protracted active phase already there are adequate contractions, then the reasons may be either CPD or OP position. CPD means cephalopelvic disproportionation, or OP means occipito-posterior. So in CPD you should do per vaginal examination. If molding and caput molding or slow progress both are present together, then you should go for trial of labor, because in CPD you can go for trial of labor. In trial of labor, if the delivery happen, okay, then the process is done. If not, then there is fetal distress, then do cesarean section. And if there is arrest of labor, then also do cesarean section. Okay, coming to OP, in occipito-posterior position, do per vaginal examination. Then you will see a triangle fontanelle facing sacral promontory. Then you need to wait and watch here. Okay, Now let us discuss about active phase arrest. What is active phase arrest? So active phase arrest, it is there is no change in cervical dilation even after 4 hours with adequate contractions. There are adequate contractions, but still 4 hours has passed, still no change in cervical dilation, and 6 hours has passed with inadequate contractions. Okay, so for example, if you take a patient has come to you in the 4 p.m. in the evening, okay, and her cervix is 6 centimeter dilated and she is already in active phase, but again you will see her at 6 p.m. So morning you are seeing at 4 a.m. Now you are seeing at 6 p.m. in the evening, and you see her cervix is only 7 centimeter dilated. That is protracted active phase, right? It's a protracted active phase because there is a slow progress. You can see in the morning 6 centimeter, now it is evening 6 p.m. but still 7 centimeter, right? So it's a protracted active phase. Now coming to example 2, here on the 4 p.m. you have seen the uterus is cervix is 6 centimeter dilated in the active phase, and in the evening 6 p.m. you saw that she is still 6 centimeters, no change. Then you need to wait for 2 more hours. Okay, so after waiting for 2 more hours at 8 p.m. if you see, again at 8 p.m. it's still 6 centimeters. So it is nothing but it is indicating the arrest of active phase. Okay, so fetal distress is present at 7 p.m. Do not wait till 8 p.m. Operate immediately. So if you find any fetal distress in between, then you should operate, do cesarean section. If not, then you can wait and you can confirm it as arrest of active phase. So before making a diagnosis of arrest, before making a diagnosis of arrest, check membranes are ruptured. Without membrane rupture, do not make a diagnosis of arrest. Okay, so always remember, in the arrest of active phase there is always a rupture of membranes. Okay, this is very important. And fetal heart rate should be normal, no fetal distress on partograph seen as plateau. So before making diagnosis of arrest, you should see first point this one. Second point, you should see that the fetal heart rate should be always normal, no fetal distress should be present, and it should be seen as a plateau. Next, coming to management, do the C-section, and if the fetal distress occurs, do not wait for 4 hours, take immediately for C-section. So arrest is seen actually in active phase or second stage. Active phase is also called second stage of labor. Okay, not a diagnostic, not a diagnosis to be made in latent phase. Never make a diagnosis in latent phase. So by this we completed the part 1 of abnormal labor. Next we'll start with part 2.